Percutaneous tracheostomy was introduced in the 1970s by Toy and Weinstein. Over the years, it has been refined and demonstrated to be safe and effective when compared to surgical tracheotomy. Physicians should be properly trained prior to attempting this procedure. The use of bronchoscopy has become a standard of practice to ensure patient safety. Prior to insertion, the integrity of the cuff and inflation system needs to be checked by fully inflating the tube cuff. If satisfactory, fully deflate the cuff, smoothing it back towards the flange as it deflates. This will avoid rupture during tube insertion and minimize insertional force of the tracheostomy tube. Check to make sure that the inner cannula has been inserted and removed from the tracheostomy tube. IV conscious sedation, including a short-acting paralytic, is administered to the patient, and the patient's inspired oxygen is adjusted to 100%. If not already in place, a patent airway must be established with an endotracheal tube to ensure adequate oxygenation and ventilation during the procedure. The surgical site is disinfected with chlorhexidine, and a surgical drape is applied. After appropriate local infiltration with the epinephrine and lidocaine at the surgical site, make a 1.5 to 2 centimeter incision and perform exploratory blunt dissection to identify the anatomical landmarks and identify the possible presence of anterior jugular veins. With the aid of the bronchoscope, position the endotracheal tube cuff just below the level of the vocal cords and inflate the cuff. Care must be exercised to ensure the needle guide wire, guiding catheter, and dilator do not perforate the posterior tracheal wall. If using the needle cannula assembly, remove the needle leaving the cannula in place and advance the guide wire using the single-handed guide wire introducer. If using either the 5 or 7 centimeter guide wire introducer needle, advance the guide wire directly through the guide wire needle. Advance the lubricated 14-gauge short pre-dilator over the guide wire with a slight twisting motion through the soft tissues and anterior tracheal wall as confirmed by bronchoscopy and avoiding contact with the posterior tracheal wall. The dilator is then removed, leaving the guide wire in place. Advance the pre-assembled water-lubricated guiding catheter and tapered dilator over the guide wire and position such that the black indicator is at the skin level. Align the proximal end of the guiding catheter that exits the blue perk dilator with the proximal band mark on the guide wire to reconfirm proper placement of the guide wire. Insert and partially remove the dilator several times in order to slightly overdilate the trachea to a size appropriate for the tracheostomy tube. The dilator is marked with a 38 French gauge maximum insertion depth mark, which is visible on bronchoscopy, and it should not be inserted beyond this point. A solid black mark is also visible on the dilator and should not be advanced past the skin level. Insert the lubricated tracheostomy tube loaded on its lubricated introducer over the guiding catheter until full contact with the safety stop is achieved. Position the tip of the introducer and tracheostomy tube perpendicular with the insertion site, accounting for the curvature of the tracheostomy tube. Advance the tracheostomy tube into the trachea in an arc and guided by bronchoscopy. To ease removal of the introducer, guiding catheter, and guide wire, the tracheostomy tube flange and connector should be firmly held while the introducer is withdrawn in an arc-like movement toward the patient's feet. As required, insert the inner cannula, ensuring it is securely inserted. The inner cannula provides a slight snap to indicate its correct positioning. The tracheostomy tube should also be secured using the Portex tracheostomy tube holder.